И следующая тематика нашего туториала – это неходжкинские лимфомы. Я с удовольствием предоставляю слово профессору Франку Маршхаузеру. Он является профессором госпитального центра Лильского университета. Это Франция. Мы с ним уже знакомы не первый день. Не первый год, скажем так, он приезжал к нам много раз, и есть возможность обсуждать случаи в разных вариантах. Но сегодня мы начнем с того, что он представит свою лекцию по неходжкинским лимфомам, и после этого мы будем разбирать клинические случаи. So, please, Frank, we are ready to listen to you.
Thank you, Irina. These are my disclosures. So my talk today will be on optimizing treatment of relapsed refractory follicular lymphoma. And just to set the stage, I think we know now that following the PRIMA and the Gallium trial, we have managed very nice median progression-free survival. And the challenge is for those few patients that will be in failure to have the optimal treatment. I wanted to show you this cartoon describing the hypothetical disease progression in follicular lymphoma in the different ways. You can see that 20 to 33% of the patients will have slowly progressive follicular lymphoma that doesn't transform. The majority of the patients, 60 to 65, will have slowly progressive follicular lymphoma, but at risk to transform, with an incidence around 2 to 3% per year, and different pathways, one with 6q minus deletion, and another one with other chromosomal damage gain, and then it would result in genetic losses. But you also have 5 to 10% of the patient who will have aggressive follicular lymphoma not at risk to transform. And here maybe there is defective immune response or another critical genetic event that we don't know, but still in those non-transformed patients there will be an accelerated disease course. And it's extremely difficult to make a choice in follicular lymphoma because you have many different treatment options, going from watch and wait to very new agents, but you can also have palliative radiotherapy or allogeneic transplantation. So how can we make a choice in this difficult context? I think we should look at the line of relapse. Is it the first relapse, the second, or more than the second? Do we have refractory disease? Do we have a very short time to progression with an early PD that is within 1 year of diagnosis or 2 years? Or is it a late PD? And how should we define a late PD? Is it more than 2 years? Is it more than the presumed median PFS, which is now around 7 years with immunochemotherapy regimen? It also really depends on the previous treatments and if the patient has histological transformation, and of course the patient age, comorbidities, and wishes are important. What we now know, at least since 2015, is that POD24, that is progression of disease within 24 months of first chemotherapy, seems a reliable prognostic tool, and that is for 90% of the patient a worse outcome. Can we predict that, or can we predict refractory disease? We have tested many things. FLIPI-1, the FLIPI revised, immunohistochemistry score looking at the macrophages infiltrations. We have looked at PET with SUVmax and now the tumor volume. We have looked at gene expression profiling and more recently to combined clinical biologic models, M7 FLIPI, POD24 PI, TMTV at baseline plus FLIPI revised, and more recently even PRIMA PI that has been validated by Emmanuel Bachy. Once you have started treatment, we have now more interesting tools that are still in the research setting, molecular residual disease with circulating DNA, or disease progression transformation in some clones showing molecular transformation. But this is not routine, this is all work in progress. And so far you cannot rely on those factors. And in the end, your objective should be to reach the longest disease control. Is it important to reach CR? Nobody knows. It seems that with some very cytotoxic regimen, CR is increased, but the most important is to preserve the quality of life and use less toxic regimen even if you don't achieve CR. The goal in those patients that live long is to avoid long-term toxicity. These are the ESMO guidelines in 2016, and you see that you can do everything you want. So you give any types of immunochemo regimen as part of the relapse salvage setting. If you are young, less than 65, you can consider autologous stem cell transplantation, but you also can consider new agent, radioimmunotherapy, idelalisib, and the same is true for elderly patients except for autologous stem cell transplantation. So the main question to me are, is autologous stem cell transplantation part of second-line therapy, and if yes, for whom? You first have this trial published by Ruth Pettengill in JCO, but this was a randomized trial with many patients before of the era of rituximab as part of the first-line therapy. So there was clearly a benefit of autologous stem cell transplantation and getting rituximab either at the purging or in maintenance, but this is now not up to date anymore, as most of the patients will have received rituximab before. We have retrospective data from the German group, at least 2 series, showing, here you see on the red curve, that if you are POD24 and you do not receive autologous stem cell transplantation, you do poorly. And what you should look at is the median PFS here. So if you are here and you get an autologous stem cell transplantation while you are POD24, you see that at 2 years you are around 60% PFS, with a much better overall survival around 75%. Keep those numbers in mind. In those series that was not considered was the histological transformation, and we looked at the histological transformation in the PRIMA study. You see that it's difficult to biopsy all the patients. Among those 463 that had disease progression, we could only biopsy 42%. And among those, only 20% were transformed. But most importantly, we saw that progression appears to occur early. So if you have histological transformation, it's within the first year, and you see that it's 10 months versus 23 months here. And we also showed that more than 37% of the patient of the biopsy performed during the first year showed transformation, which means 58% of all histological transformation. A recent series from the group of Laurie Sen in patients that received bendamustine rituximab showed that, in fact, most POD24 were transformed disease. And in that cases, you see that the prognostic was really dismal. So maybe POD24 is not the accurate measurement outside of clinical histological transformation. Clearly, the transformation is the poor event, and if we looked at the PRIMA studies again, you see that if you have follicular lymphoma that relapse without transformation, you are doing pretty well, and you will die from other causes. If you have histological transformation, this will be the main trigger of death. And so far, as I told you, the clinical features remain the only routine available method for identifying high risk factor. That means alterated performance status, elevated LDH, anemia. A higher risk is also seen if you have follicular grade 3A at beginning. And if you have a high FLIPI score or increased beta-2 microglobulin over 3 milligram per liter. You also should know that histological transformation emerges from expansion of clones that are rare in the diagnostic sample. This is work from Robert Creedle that shows you that here the small clone appears and then gives histological transformation. This is not the only case. You have 4 different options, but this is the most frequent. So it's very difficult to predict unless you have a very powerful molecular tool. What we could show in the PRIMA trial, even if it's on a low number of patients, is that you only benefited of autologous stem cell transplantation if you had histological transformation. But if you were relapsing with follicular lymphoma, there was no difference in giving a standard salvage and autologous stem cell transplantation. And we also had a closer look whether POD12, progression within 12 months, or POD24 was important if you relapsed with follicular lymphoma histology, not transformation. And here again, no significant difference. So the clear message is autologous stem cell transplantation as part of second-line treatment, yes, but if you have transformed disease, maybe not if you have follicular lymphoma. Is there a role for new monoclonal antibodies? You all know this cartoon showing that GA101 has distinct features with an enhanced direct cell death as an enhanced ADCC. And we also show that in 3-dimensional models and cell culture, calling MAX, there is some different features with obinutuzumab showing that the penetration is much better with this antibody compared to rituximab. So this molecular differences translate in a different behavior in the clinics. And this is why we felt it was a better drug in the relapsed and refractory setting, and we could show that we had a signal of better efficiency here in patients that were refractory to rituximab with a 50% of a response rate with GA101 in those patients that were rituximab refractory. And this prompted the Gadolin study, which you are very familiar with, that compared bendamustine obinutuzumab with bendamustine alone. Just keep in mind that the median line of prior therapy was 2, and that most of the patients were double refractory, that is, refractory to rituximab plus an alkylating agent. Only a minority was refractory to rituximab as a single agent. The overall response rate was nice, but keep in mind that the CR rate was very low, less than 20%. This is important when you want to compare to new treatment strategy later on. Again, you know these numbers, you know this data, but look at the numbers. Here, if you are follicular lymphoma, your median PFS is close to 2 years. Close to 2 years with Gadolin. And this is an early doubling, while the overall survival is not reached. We will come back to that later. More importantly, and probably in the case of Lally, you will see that this is important, the safety might be a concern with an increased incidence of febrile neutropenia, an increased incidence of infections, a slight increase of second neoplasia, but in terms of grade 5 fatal AEs, it was okay. What we could show in the Gallium trial was that the incidence of fatal grade 5 AEs was more important when you use bendamustine in combination with GA101. So the question of a durable maintenance with GA101 when you have given bendamustine is an important question with the increased incidence of AE. What about new agents? We now realize that the microenvironment is extremely important in follicular lymphoma, and that the bone marrow has a different tumor niche than the lymph node, and that the interaction with the stromal cells, but more importantly the immune cells with all the CD8, NK, Treg, and macrophage is extremely important. And when you try to give some explanation of the interaction with the microenvironment, I think we can distinguish the bad guys here. Okay, so you have the T follicular helper cells, the Treg cells, and the stromal cells. The good guys, so you have the CD8 cells, the NK cells, and the T gamma delta cells, and you have what I call the ugly guys. Sometimes they are good, sometimes they are bad, the macrophages. And we know from lenalidomide that we have a very potent immunomodulatory drug that may affect all the different components that are important in the microenvironment, the NK cells, the T cells, and also some effect on the macrophages. But most importantly, we have shown that in combinations with anti-CD20, it restores the immunologic synapse. And this makes this regimen very attractive in combination with anti-CD20 antibody. We have now many demonstrations of the efficiency of the R-square regimen, but I think the most recent one was the Augment trial that was shown by John Leonard at ASH, showing that in patients that were relapsed refractory to follicular lymphoma, but not refractory to rituximab, so some bias towards a more favorable population, when you randomized R-square to R placebo, and for a regimen that is given over 1 year, you had an increased overall response rate and CR rate compared to rituximab as a single agent, and this was significant both for the independent review committee and the investigators. But you also had, and this was the primary endpoint, a benefit in terms of progression-free survival for R-square compared to R placebo, with nearly a tripling here of the median PFS. It's important to keep in mind that the judgment of the investigators is also important in real life, and here you see that it was more a doubling than a tripling, but still a very significant benefit. What was a good surprise, and that was not expected because it was only a secondary endpoint, you had a hazard ratio of 0.6 for overall survival. So there was a benefit in overall survival, which is always very difficult to show in follicular lymphoma. And this came from a better disease control, and the good surprise also was that there was no more histological transformation, and even less in the R-square regimen, and less second malignancy, knowing that with lenalidomide is always a concern that you could increase the rate of second malignancy. And here, no signal. Keep in mind that in the relevance trial, which was given in the first-line setting, you also had an equivalence of R-square with R-chemo, which was very difficult to beat. So a clear scientific success for a non-chemo regimen. And also, as conclusions from this trial, we had a less important toxicity and no difference in terms of second primary malignancy, which makes R-square now a package that is extremely strong in follicular lymphoma. How much can we build on R-square to further improve the prognostic? Should we add drugs like lenalidomide, which at least in Europe is approved in the double refractory setting? These are the data as a single agent in patients that have received more than 4 lines of chemotherapy and that were really hard to treat. A median PFS of 1 year and overall survival response rate of 57%. But we had a bad surprise when we combined that with R-square. We had a very important increase of the toxicity due to a probable excessive immune activations with patients dying. So you cannot combine lenalidomide plus idelalisib. Can you use another BCR inhibitor, namely a BTK inhibitor? Ibrutinib as a single agent is not very efficient in follicular lymphoma, but maybe through another interaction with the microenvironment, such as a T-cell ITK inhibition, you could gain something by adding to R-square. But again, this was not the case. There was a slightly improved response when you combine ibrutinib to R-square, but there was also an increased toxicity, and this combination in the first-line setting was not continued. Can you replace the monoclonal antibody? I show you that GA101 looks promising, at least in combination with chemotherapy. So we tried in the GALAN regimen to combine GA101 plus lenalidomide, and we had nice over-response rate, but again, the CR rate, even if better than, for example, in the GADOLIN trial, even if all those patients were not refractory, you are still less than 50%, okay? The good surprise here was that if you had POD 24, you had a very nice PFS and a very nice OS. And this was not significantly different from those that had a later relapse. And look at the numbers here. 2 years PFS, 62% if you are POD 24, and 82% overall survival. Exactly the same than with autologous stem cell transplantation or the GADOLIN regimen, or very similar. Even if it's cross-comparison and historical data, you can see that this immunomodulatory regimen can challenge both autologous stem cell transplantation and the GADOLIN trial. Looking at the refractory, the data were not significantly different, even if a little bit lower. The 2 years PFS was 52%. Remember, median PFS with GADOLIN 25 months. Okay, it is exactly the same. And the overall survival remains pretty good. And this regimen was considered attractive enough to be tested by the Americans as one of the test arm in the relapse refractory setting, another one with PI3 kinase inhibitors and obinutuzumab and CHOP obinutuzumab after failing in 24 months a bendamustine plus anti-CD20 regimen. To further continue the development of the GALAN regimen, we decided to test the addition of atezolizumab to the GALAN regimen, and the preliminary data were shown at ASH by Gilles Salles. This was the regimen. You see that atezolizumab is added after the second cycle, and the baseline characteristics of the patients were nearly the same than in the GALAN regimen. You see that refractory to last line, 28%, refractory to last treatment, 48%, POD 24, 31%. And in those patients, what is interesting is that the CR rate here, according to Lugano criteria, was much higher. You are now close to 80%, 85%, and we will show in Lugano that the molecular response rate in those patients was also extremely good. So compared to the other regimen, you see that here we increase the CR rate with this kind of regimen. Within the LISA group, we have also tested other combinations with atezolizumab and GA101. So this is an example of a combination with venetoclax. In the GATA regimen, the preliminary data will be shown at Lugano also. I did not mention EZH2 because I did that in another conferences, and there might be also a label for this drug in the future, but I wanted to end my talk by the most interesting, I think, for the future are the T-cell engager against B-cell lymphoma, which are the BiTEs here, so the bispecific antibody, and the CAR T cells. There were data at ASH this year showing the good results with the bispecific antibody, showing that this drug, you see that it's a 1-to-1 here, one side to go to the T cell, CD3, and one side to fix to the CD20. It redirects the T cells to engage and eliminate the malignant B cells. It's a conditional antagonist, and of course, there is an amino acid substitution to inactivate ADCC, otherwise this would be a storm in the body. And look at the waterfall plot in patients with follicular lymphoma that had received a median of 2 prior lines of therapy. This looks extremely impressive. And you see that most of those responses here with the bispecifics are durable. There is also another, which is to me even more promising, bispecific antibody, which is this time a 2-to-1 format with undiminished activity in presence of residual anti-CD20 from previous line of therapy. And we know that all of those patients are overflooded with either rituximab or GA101. But this drug is so avid that it's not a problem at all to give it, even if you are saturated with the monoclonal anti-CD20. So you have the ability to combine with other anti-CD20. We have only very preliminary data, as most of the efficiency was shown in patients that had diffuse large B-cell lymphoma, but in the 5 to 6 patients that had follicular lymphoma, all achieved a CR. Finally, the CAR T cells, I know it's not available in Russia so far, but you have this update with the CTL19 that were presented in some congresses for patients that had failed at least 3 lines of prior therapy or were refractory. So you see that the PFS was 73% and most of the responses were durable. And if you compare to the last prior line of therapy, this is very significant. When you have this in mind, even if we need now more follow-up, you see that it looks much better than allogeneic stem cell transplantation. I listed here a very small series of single institution or few institution series, and you see that the 3 years EFS and PFS is not fantastic. And moreover, the toxicity is not nothing. Of course, the CAR T cells is toxic, but it's less toxic than that. So my conclusion, after showing all these options, is that, first of all, autologous stem cell transplantation is better only if you have histological transformation, but we can discuss that. We have now many new regimens that challenge autologous stem cell transplantation in refractory follicular lymphoma. We have new strategies that target both the microenvironment and the tumor. And the future of all these new agents is in combination, but we need a better knowledge of the biology if we really want to impact treatment choices. You can consider allogeneic stem cell transplantation of CAR T cells after at least 2 lines, 1 line of immunochemo well conducted and 1 line of immunomodulation well conducted. And you have then clinical trials. So probably after 3 lines, you can consider either CAR T cells or allogeneic stem cell transplantation. And currently, my final statement with that, immunomodulation strategy have the highest potential to change the disease history in follicular lymphoma. Thank you for your attention.
Thank you very much, Frank. So, questions, please? So.
Thank you, Frank. Very nice presentation. The first question is about polatuzumab vedotin. You don't talk about this. What is the place for this drug?
So we had nice data with polatuzumab as a single agent in follicular lymphoma or in combination with either CD20 with rituximab and GA101. But you may also remember that when it was tested in a small randomized phase 2 study in combination with bendamustine rituximab, there were no significant difference between the BR pola arm and the pola as a single agent, or the BR alone. So I would say that maybe it's not the best place, polatuzumab in follicular lymphoma, unless you combine it in a different way with other drugs that are not chemo drugs. Currently, you have trials testing the combination of polatuzumab plus lenalidomide and polatuzumab plus venetoclax in follicular lymphoma. And there might be a very good place for polatuzumab in follicular lymphoma. But if you combine with chemotherapy, I'm not sure it adds a lot.
Thank you. Еще? Пожалуйста, да, пожалуйста, Елена Николаевна.
Could you comment on radiotherapy? What is the place and the time? To whom and when?
So this is a very either religious or cultural question, I would say. we try to avoid radiotherapy as much as possible, but it's a very good treatment to us in the palliative setting, or in some cases with localized disease where you can give small doses of radiation. But I would say that we have no strong data supporting radiotherapy. We only have retrospective data, the biggest one being the Canadian registry, and in the end the patients always will relapse. So it helps, but if you have other options, knowing that most of the time, even if the disease is localized, you have some clones that circulate, I would prefer other options with systemic treatments.
Да, так, еще коллеги? Да, пожалуйста, Галина Сергеевна.
What is, in your clinical practice, first-line treatment for follicular lymphoma if the patient needs the treatment? Bendamustine or R-CHOP? What do you prefer? Or obinutuzumab, maybe?
So again, it's a very cultural question. In France, I think 70% of the patients are getting CHOP plus an anti-CD20. Most of the time it remains rituximab, but now GA101 is progressively increasing, and I would say it is reaching 20 to 25%. So there is it's very difficult to select the patients you would like to give GA101 instead of rituximab. I think if you believe the gallium data, you should give GA101 to all the patients, and I think this is the best way to interpret the data. But we all know that in the clinical practice, there is a trend to give more GA101 in more serious and younger patients, or you give it with CVP in elderly patients. So it's you increase the efficiency while reducing the toxicity. Bendamustine is not given in France, is not very popular, but we know that it's exactly the opposite, at least in Germany, where 70% of the patient will get that. What we fear in France, and it's more something that is a belief that has been demonstrated, is that if you give bendamustine, you affect the T cells for the future. And as we strongly believe that immunomodulation is the most important thing in follicular lymphoma, we would like to preserve this possibility, and therefore we do not give bendamustine. But I agree that this has to be demonstrated, and my German colleagues would probably disagree.
Okay, thank you. Так, еще один вопрос, пожалуйста, коллеги, если есть. Yes. So, thank you very much for your brilliant presentation. And we continue. Лаля Галимовна Бабичева с клиническим случаем, пожалуйста.
Добрый день, уважаемые коллеги. Я рада вас приветствовать, рада приветствовать наших гостей. Господин Франк Марчхаузер снял почти все вопросы, которые были у меня по поводу дальнейшей судьбы наших пациентов, но, тем не менее, я озвучу эти случаи, и в первом из них хочу обратить внимание на ту проблему, которой, к сожалению, нет систематического подхода, по крайней мере, у нас в стране, и тоже у меня будет вопрос к нашим коллегам зарубежным, какой у них рутинная практика, как они к этому вопросу подходят. Итак, первая пациентка, 58 лет, она обратилась в начале 2016 года по месту жительства в поликлинику с жалобами на боли в области сердца, на дискомфорт при дыхании, на боли в подреберье. Был выявлен левосторонний плеврит и генерализованная лимфоденопатия. Пациентка была направлена к гематологу. И в марте 2016 года выполнена биопсия пахового лимфатического узла. При морфологическом исследовании обращает на себя внимание стертая структура лимфатического узла, диффузная пролиферация лимфоидных элементов. Была выявлена иммуногистохимическое исследование со стандартной панелью. Пролиферативная активность была менее 10%, не более 10%, и диагноз звучал следующим образом. Фолликулярная лимфома, диффузно-нодулярный тип роста, первый цитологический тип. В общем анализе крови обращала на себя внимание умеренная лейкопения, тромбоцитопения. Биохимический анализ крови не вызывал каких-то опасений, ну, вообще анализ мочи без патологии. 29 марта 2016 года пациентке выполнена была позитронная эмиссионная томография. Обнаружены гиперметаболические очаги, локализующиеся в проекции всех групп периферических лимфатических узлов и средостения. Кроме того, обращала на себя внимание гиперфиксация препарата во всех костях. Уровень накопления СУФ-6. Также выполнена 31 марта 2016 года компьютерная томография. Отмечено генерализованное вовлечение лимфатических узлов по обе стороны диафрагмы. Максимальный размер – это конгломерат вокруг магистральных сосудов брюшной полости, который превышал 12 сантиметров в своем размере. Имеется жидкость в плевральной полости в левой, печень увеличена, определяются несколько небольших очагов. Кроме того, определяется образование в проекции тела поджелудочной железы и изменения в структуре поясничного позвонка. Диагноз, пациентка наблюдалась по месту жительства, к сожалению, данных за выполнение трепанобиопсии нет, то есть поражение костного мозга не подтверждено. Диагноз звучал следующим образом: фолликулярная лимфома первого цитологического типа с генерализованным вовлечением лимфатических узлов по обе стороны диафрагмы, костей скелета, печени, поджелудочной железы, плевры, левосторонний плеврит, 4 А-стадия. Итак, пациентке принимается решение начать лечение по схеме РЧОП с применением пегилированного липосомального доксорубицина. Пациентка получает 9 курсов. Ну тоже почему 9? Тут такой вопрос стоит. Но достигнута после 9 курсов лишь частичная ремиссия. И на область конгломерата брюшной полости было принято решение провести лучевую терапию. Пациентка получает лучевую терапию на эту область. И далее тоже по непонятным причинам пациентка не получает поддерживающую терапию ритуксимабом, а остается под динамическим наблюдением. Лечение окончено 29 декабря 2016 года. Динамическое наблюдение, данные компьютерной томографии вы видите по окончанию лечения небольшие лимфатические узлы максимальным размером 2 см, правые подвздошные. Уже в феврале отмечен незначительный рост лимфатических узлов до 3 см в максимальном размере. И далее уже исследование в мае, я на нем подробнее остановлюсь, вы увидите совершенно четкое, более чем в 3 раза увеличение размеров лимфатических узлов. Пациентка обращается в онкологический научный центр. Менее чем через 6 месяцев после окончания лечения мы проводим обследование. В общем анализе крови обращает на себя внимание опять-таки лейкопения и тромбоцитопения. Биохимический анализ крови без клинических значимых отклонений. Лактат дегидрогеназа уровень 271, норма. Выполнена трепанобиопсия. Морфолог описывает изменения в костном мозге как нежный склероз, остаточная опухоль под вопросом. Выполняется компьютерная томография 12 мая 2017 года. Данные эти были уже в таблице, сравниваются с динамическим наблюдением от февраля 2017 года. Мелкие лимфоузлы в средостении до 1 см, они не изменились. Увеличились лимфоузлы в правой подмышечной области. Остается без изменений тот самый муфтообразный конгломерат, на область которого была проведена лучевая терапия некоторое время ранее. Далее увеличились лимфоузлы в правой подвздошной области до больших размеров 6,7 на 3,3 см. В правой паховой области тоже увеличились лимфатические узлы и отмечают неоднородную структуру поясничного позвонка. Итак, начинается вторая линия терапии. была возможность уже провести пациентке лечение, уже были данные по исследованию Гадолин, которое уже озвучивалось. Была возможность пациентке провести лечение обинутузумабом с бендамустином. Первый курс она получила бендамустина в монорежиме 120 мг на метр квадратный. И далее 5 циклов химиотерапии по схеме обинутузумаб плюс бендамустин с нарастающим противоопухолевым эффектом. После 6 курсов выполнена компьютерная томография. Мы видим все-таки некие остаточные образования, и результат трактуется как частичная ремиссия. Но 6 курсов уже проведено, и далее принимается решение пациентке проводить поддерживающую терапию обинутузумабом. В феврале и в апреле получает пациентка первые 2 введения обинутузумаба в поддерживающем режиме, и в мае уже диагностируется двусторонняя нижнедолевая пневмония при компьютерной томографии. Кроме того, отмечает на себя внимание отсутствие лимфаденопатии, то есть лимфатические узлы не увеличены, то есть констатировано после 2 введений обинутузумаба в поддерживающем режиме, констатирована полная ремиссия. От продолжения этого лечения решено отказаться в связи с инфекционными осложнениями, и ситуация была в мае, а в сентябре у пациентки отмечается повторная правосторонняя пневмония, при этом полная ремиссия сохраняется. Определяется уровень иммуноглобулинов, вы видите, гипогаммоглобулинемия не выявлена, иммуноглобулин G 5,96 грамм на литр, проводится антибактериальная противогрибковая терапия, и уже в ноябре 2018 года пациентка снова отмечает повышение температуры тела, кашель, боли в горле, проводятся соответствующие исследования, опять-таки определяется уровень иммуноглобулинов, опять иммуноглобулин G не снижен, но учитывая уже 3-й эпизод инфекционных осложнений, пациентке назначается заместительная терапия иммуноглобулинами и соответствующая антибактериальная противогрибковая терапия. К счастью, на сегодняшний день пациентка сохраняет полную ремиссию, и это, наверное, объясняется уже данными тех исследований, которые проводились по достаточно высокой частоте достижения МОП-негативных ремиссий при использовании новых моноклональных антител. Вероятно, нам удалось этого достичь. Пациентка продолжает заместительную терапию иммуноглобулинами и остается в полной ремиссии. Вот. Были вопросы по поводу возможной дальнейшей тактики. Как раз я хотела спросить у профессора Мочхаузера по поводу возможности сочетания леналидомида с обинутузумабом, наверное, или других схем. Он уже на эти вопросы все ответил. И я готова ответить на вопросы по этому случаю и, в свою очередь, спросить у наших зарубежных коллег, какова рутинная тактика у пациентов с гемобластозами по поводу возможного развития вторичных иммунодефицитов.
Франко?
So our experience is exactly the same than yours. So in the few patients in whom we give, as part of the relapse or refractory setting, gathering with long-term GA101, we had this immunodepression. And so now our policy is to try to prevent that, and we stop as soon as we have the first infectious alert, we stop the maintenance. The supplementation with IgIV makes sense in most of those patients, but probably if you limit the number of infusion of GA101 or the number of courses of bendamustine to 4 instead of 6, this is our preferred option. If this patient should relapse, probably I would try the Galen combination in this particular setting, depending on the duration of response. But again, I would then use a very short regimen. We have developed a regimen that lasts 2.5 years, but you see from the augment data that 1 year should be enough and maybe 6 months. So for those patients, this is what I would tend to do.
Спасибо большое. И еще один, если можно, вопрос у меня. Руководствуетесь ли вы уровнем иммуноглобулина G без наличия клинических проявлений инфекционных или только плюс инфекционные осложнения? И наоборот, если иммуноглобулин G нормального уровня, но есть инфекционные осложнения, то как здесь вы поступаете?
That's a very good question. I think the clinics is always the most important. If you have no clinical alert, even if you are close or less to 3 grams per liter of immunoglobulin, I would not replace. If there is clinical problem, infection, then I replace.
Спасибо большое.
Валерия Григорьевна, хотела бы уточнить, как часто вы сталкиваетесь с очень продолжительными в течение нескольких лет цитопеническими синдромами после использования бендамустина, то есть вот БР-курс, и потом в течение многих лет сохраняется лейкопения, тромбоцитопения?
Не часто, но есть. И, как правило, у предлеченных пациентов, у тех пациентов, которые получали БР, в первую линию мы крайне редко даем, во вторую, в третью, в первом рецидиве такого мы не видим. А вот что касается вторичного иммунодефицита и длительных потом инфекционных осложнений, таких пациентов очень много. Даже независимо от того, получали они бендамустин именно или нет. Даже от стандартного лечения с использованием ритуксимаба, те же, например, 8 курсов РЧОП и 2-летняя поддерживающая терапия, и есть пациенты, которые много-много лет потом страдают от герпес-вирусной инфекции, например. Вот буквально на днях я отправила пациентку на обследование к иммунологам, как раз-таки такое более глубокое.
One more question. Еще один.
Спасибо большое, Валерия Галимовна, за презентацию замечательного, интересного случая. Я хотела просто уточнить, делали ли вы rebиопсию при прогрессировании заболеваний, когда пациентка к вам поступила?
Да, в данном случае не делали. Это был короткий срок, но мы, как правило, к этому прибегаем, если есть хотя бы там какой-то период благополучия, получен эффект. Но здесь практически все это было подряд, и не было такого это было исходные зоны, в общем, как бы не возникло такой необходимости делать повторную биопсию.
Спасибо.
Профессор Витила?
Just a brief comment to what you said before regarding bendamustine, because unlike the French colleague, we are using bendamustine in first line more often. Honestly, if you use bendamustine in first line, it's not so common to have prolonged cytopenia or infection, also because we are using Bactrim prophylaxis and then cyclovir prophylaxis with bendamustine, and so. But you are right, and Frank is right, that when you use in second line, the majority of our patients were not able to receive 6 courses of bendamustine, but we usually give only 4 courses of bendamustine plus anti-CD20, and then rituximab or now obinutuzumab in some cases, and now before the maintenance. So in second line, probably safer to give 4 courses, or maybe to reduce the dose at 70 milligrams could be another option.
Thank you. Комментарии кого-то? Галина Сергеевна, не хотите ничего? Тогда второй случай, пожалуйста.
Позвольте представить вам второй случай. Это пациент 52 лет. В октябре 2011 года обнаружил у себя увеличение лимфатических узлов шейных, сделал ультразвуковое исследование, выявлена генерализованная лимфаденопатия, заподозрено было лимфопролиферативное заболевание. Пациент обратился в диагностическое отделение онкологического научного центра. При обследовании отмечается генерализованная лимфаденопатия, увеличение размеров печени. В общем анализе крови отмечает лейкопения, анемия, тромбоцитопения. Биохимический анализ крови не вызывает каких-либо опасений. Уровень лактат-дегидрогеназы нормальный. Делается компьютерное исследование, определяются увеличенные лимфоузлы в средостении. Кроме того, изменения в легких. Большой конгломерат в проекции ворот почек 10 на 7 сантиметров. Кроме того, увеличена печень, есть дефекты контрастированного и есть спленомегалия. При ультразвуковом исследовании также генерализованная лимфаденопатия, причем подмышечные лимфатические узлы достаточно больших размеров, около 7 см в максимальном размере. Выполняется биопсия наиболее крупного лимфатического узла подмышечного справа. При иммуногистохимическом исследовании мы получаем заключение: фолликулярная лимфома первого цитологического типа с нодулярно-диффузным характером роста. Пролиферативная активность невысокая, 5-7%. Выполняется трипанобиопсия, костный мозг гиперклеточный за счет интерстициально-диффузного разрастания лимфомы из небольших клеток, то есть поражение костного мозга подтверждается. Таким образом, диагноз звучит следующим образом: фолликулярная лимфома первого цитологического типа с поражением медиастинальных, периферических, внутрибрюшных, забрюшинных лимфатических узлов, печени, селезенки, легких, костного мозга 4А стадия. Что касается прогностического индекса, то мы имеем 3 неблагоприятных фактора, касающихся распространенности, и плюс у пациента была анемия в дебюте заболевания. Пациенту начато лечение, учитывая, что это первый тип фолликулярной лимфомы по схеме RCVP. При этом через 15 минут начала инфузии ритуксимаба мы получаем анафилактическую реакцию в виде острой дыхательной недостаточности, развернутой картины с эпизодом потери сознания. Второй курс также пытаемся провести в полном объеме в надежде, что на второе введение такой реакции не будет, но тем не менее тоже сразу же в начале инфузии появилось затруднение дыхания, покраснение, крапивница, поэтому последующие курсы до 8 проводились без ритуксимаба, просто схема CVP. После 6-го курса выполнялась позитронная эмиссионная томография, и была обнаружена резидуальная активная ткань левой подмышечной области и пахово-бедренных областях с обеих сторон. Поэтому после 6-го курса констатирована частичная ремиссия и проведены еще 2 курса CVP без моноклональных антител. Ну и от поддерживающей терапии тоже решено было отказаться в связи с непереносимостью. Через год при ультразвуковом исследовании обнаружена опять-таки генерализованная лимфаденопатия, то есть есть подозрение на первый рецидив заболевания через год. Начата 2-я линия терапии, первый курс бендамустин в монорежиме в стандартной дозе осложнился тромбоцитопенией, лейкопенией, в связи с чем интервал был увеличен на 3 недели. Проведены 2-й и 3-й курсы также бендамустина в монорежиме, тоже с такими же осложнениями. И далее до 6-го курса была проведена уже химиотерапия в сочетании бендамустина и преднизолона. По окончании лечения определялись единичные шейные и подмышечные лимфатические узлы до сантиметра. В диаметре нечеткие, плоские. Пациент наблюдался в течение 3 лет, и через 3 года, в июне 2015 2017 года появились Б-симптомы, было отмечено увеличение размеров периферических лимфатических узлов. Кроме того, при компьютерной томографии увеличены внутрибрюшные и забрюшинные лимфатические узлы. Опять-таки доказано повторно поражение костного мозга. Таким образом, констатирован второй поздний рецидив фолликулярной лимфомы с поражением всех групп лимфатических узлов, увеличена селезенка и поражение костного мозга. По ФЛИПИ 4. Бета-2 микроглобулин повышен 4,5 мг на литр. Пациенту начинается третья линия химиотерапии. Проведено с июня 2017 года по октябрь 6 курсов химиотерапии по схеме обинутузумаб в сочетании с ЧОП. Первый курс осложнился тоже глубокой тромбоцитопенией, нейтропенией, дальнейшее лечение со стандартной вторичной профилактикой колониестимулирующими факторами. В полном объеме проведено это лечение. После 4-го курса уже было констатирована полная ПЭТ-негативная ремиссия. Поддерживающую терапию в условиях наших мы не смогли провести, но тем не менее пациент был недавно на визите, сохраняется полная ремиссия уже с мая 2017 года. Тоже, памятуя данные исследований, которые уже были озвучены, вот такая, видимо, была получена МОП-негативная ремиссия, которая длительно сохраняется. Спасибо за внимание.
Да, спасибо, Лаля Галимовна. Пожалуйста, коллеги, вопросы по этому клиническому случаю есть? Вот такая непереносимость ритуксимабу. Это не так часто, но есть, и это уже проблема становится. Ну и поэтому случай был выбран правильно совершенно для нашей сегодняшней с вами встречи. Так, Frank, do you have some comments?
No, I think this is a very intriguing cases. It's very difficult to give the incidence of rituximab intolerance and see how it translates in further intolerance in another anti-CD20 antibody. Do you think the fact that you give bendamustine as a second line made the tolerance of G101 much better in the third line? Or is this just because it's a different mechanism of action? We also have some experience of G101 after rituximab intolerance. Sometimes it's okay, sometimes it's not. It's very unpredictable. So what's your statement on that?
Сложно сказать, я даже в этом аспекте, честно говоря, не обдумывала. Но, возможно, действительно это так, потому что и 3 года, кроме того, был ремиссия. Бендамустин оказался высокоэффективным препаратом в данном случае. Возможно, действительно можно было, да, так объяснить.
Да, пожалуйста.
Dear Professor Marshall, can I ask you, you have told us that we have to prove histological transformation, whether it is or not. So how you detect the patient in whom you should do biopsy and in whom not? Because in both cases, we do not do second biopsy to prove the histological transformation.
So in this particular cases, especially with this very high beta-2 microglobulin, I would have tried to do another biopsy. I understand that the consequences would not have been very different if you try an anthracycline-containing regimen, because it would have been the treatment in any case, even in case of transformation. But I think the question is more strategical. You should now biopsy all the patients that relapse to see what happens. Let's imagine the CHOP would have been a failure, and then you would have said, okay, maybe it's transformed, maybe it's not. Even if there are not always clinical features to predict that, you should do that just to gain more knowledge and then see how it translates into the clinical practice.
So if we will see histological transformation, in this case, for example, we should go to autologous transplantation.
I think it's third line, so it's already a bit too late. But you can get that. But in any case, I would have given this first salvage regimen with anthracycline because she had not received before. If she had that received before, I would have given a DHAP or something similar. But on the other side, let's imagine there was no histological transformation. You could have tested lenalidomide or another combination. This is why. I know it's not registered in your country, but this is how we think.
Thank you.
Пожалуйста.
Я хотела вернуться к вопросу о трансформации. Вы показали в самом... Ну, у меня профессору Маршхаузеру вопрос. Вы показали 5-10% больных изначально, которые не имеют трансформации, но которые очень плохо текут. Они текут даже хуже, чем те, которые имеют трансформацию, потому что в случае трансформации у вас есть возможность дать аутотрансплантацию, может быть, помочь им. А вот этим они же не дойдут до аутотрансплантации. У вас нет окна для аутотрансплантации. Вот что вы с ними делаете? Потому что это очень большая проблема. На мой взгляд, это даже большая проблема, чем трансформация.
Yes, so in fact, the cartoon I showed you was I think in 2003, and probably things have a little bit changed in terms of incidence, but still it remains probably 5% of the patients in this situation with true follicular lymphoma and with probably different molecular mechanism. What we do for those patients now, we try the same regimen. So we try first immunochemo with CHOP. Second, we try a lenalidomide combination. And if they fail, we now try CAR T-cell.
Thank you very much, yes.
In case you cannot have CAR T-cell, these are the candidates for allogeneic.
Yeah.
У нас есть еще один комментарий, вопрос.
Можно вопрос тоже профессору?
Да, пожалуйста.
Франку Маршхаузеру. Я хотела спросить, ваше отношение к ПЭТ-исследованию при фолликулярной лимфоме в аспекте выявления трансформации и в аспекте первичной диагностики. То есть как вы относитесь вот в том случае и в этом?
So in France, we are lucky that, like in other countries in Europe, we can easily access to PET to that, but in any case. But it should not be absolutely routine to make a treatment decision. If you don't have availability, you can treat the patient without problem. In terms of predictability of transformation with PET, I think we have very conflicting data, and the more we go, the more we cannot say that PET is able to predict transformation. So if you have an SUV of 35, okay, that's fine. You should try to biopsy that lesion. But if you are between 12 and sometimes 17, you biopsy, you have a biopsy and you can find follicular lymphoma. And in fact, we even had within the LISA group a series showing that high SUV was not at all a predictor of transformation. And even the median SUV was around 14 for those that were transformed. So far, we need to gather experience of PET, but you cannot rely on PET unless it's extremely important, and probably the clinical factors are much more important to say that the patient is transformed.
Спасибо большое.
Yeah, thank you very much. Спасибо, Лаля Галимовна. So, Franco, it's your cases, please.
So, first of all, I have to apologize because I did not strictly follow the rules, and there is not only one good answer, and make multiple choices in my cases. We are not at college here. We are here to trigger discussion. So everything is not black and white in follicular lymphoma. It's more to try to learn something. So the first case is a case of a 64-year-old man who was diagnosed with follicular lymphoma in 2011, grade 2, stage 3, FLIPI2. And initially there was no treatment criteria according to the GELF, so we decided to watch and wait. Disease progression with this time occurrence of Guelph criteria occurred in February 2015, and the patient was treated, because we had this trial, in the Cavalli study. So he received 6 cycles of R-CHOP plus venetoclax. That was the cohort for follicular lymphoma. It's really real-life data I show you here. And as he was in the Cavalli trial, he did not receive rituximab maintenance. He achieved a complete response with Chesson 99 criteria, but 9 months later, 9 months after the end of therapy, PET showed metabolic progression on 2 small deep nodal lesions that were less than 50 millimeter, and he also had some bone lesion, but he was feeling very well, completely asymptomatic. But this patient had relapsed within 24 months, and I told you about POD24. So in early relapse patients, what is important? Again, you have multiple choices, but you may select the one you feel most appropriate, and then we will discuss. Shall we do a new biopsy? Is it highly recommended if technically feasible? Is PET more informative than a new biopsy? Does PET rules out histological transformation? We just discussed that. Is treatment mandatory? Or young patient in this situation should always proceed to allogeneic stem cell transplantation? May I have your votes? Okay, I think that's fine. A new biopsy is highly recommended. This is very important. PET is more informative, we just said, than no. PET rules out histological transformation, we said no. So keep that in mind. Treatment is mandatory, of course not. The patient has low tumor burden, you should watch and wait. And you have still 3% who want to bring this patient to allogeneic stem cell transformation. No, of course, you should wait more. But very good answer. So a new biopsy was technically not feasible in this patient. 2 deep lesions, 2 small lesions. What do you choose? Bendamustine obinutuzumab or DHAP, watch and wait, single agent rituximab, or idelalisib? Please vote. Okay, so the majority said watch and wait. This patient had no treatment criteria, but I see that still 20% of you want to give gadolinium just because he is POD24. Please, it's not because this patient is POD24, is asymptomatic, he's feeling well. We will see for the future, but wait until this patient has symptoms to treat him. And I see 23% single agent rituximab. This is debatable. This patient was not rituximab refractory. This could be an option, so why not? I think this is interesting. 6 months later, the patient developed fever and high fever, drenching night sweats, loss of weight, 6 kilos in 3 months. The PET showed metabolic progression on deep nodal plus bone lesion. This was a high SUV. I didn't wrote that, but it was 25. But LDH were normal, and beta-2 microglobulin was a bit elevated. And he had a C-reactive protein of 100 milligram per liter. What do you primarily suspect in this case? Infection? Histological transformation in diffuse large B-cell lymphoma? Disease progression of follicular lymphoma but with infection? Wrong primary diagnosis? Or maybe this patient has a solid tumor? What do you think? Yes, so disease progression of follicular lymphoma with this function, I think it's a very good answer. This is exactly what we had in mind. The second one, histological transformation in diffuse large B-cell, would make sense from the clinical perspective, but how do you explain the high inflammatory syndrome? Do you see that often in transformed disease? With such a high elevated CRP, this is strange. And infection alone does not cope with the clinical symptoms. So I think you made good choices. The wrong primary diagnosis, of course, you cannot say, and the solid tumor, unless the patient has a kidney cancer, it's very difficult to have such an histological, such a clinical presentation. So what about transformation in follicular lymphoma? There is a lot to read here, so take your time. Most histological transformation occur in the first year after randomization. You have a cumulative incidence of 2.4% at 1 year. POD24 may not be a strong prognostic factor when transformed FL cases are excluded. Histological transformation emerges from expansion of clones that are rare in diagnostic samples. De novo transformation has the same prognostic than secondary transformation. Or clinical features remain the only routine available methods for identifying high-risk factor. Please vote. Good. Interesting. So some of you listened to the talk. I think there is only one wrong answer. And this is de novo transformation has the same prognostic than secondary transformation. We now know from multiple series that if you have de novo transformation, you would likely behave like a diffuse large B-cell lymphoma and can expect the same response. But if you have a secondary transformation, then the prognostic is much worse. But all the rest is true. You had only one choice, so I understand. But probably the third one was the most important to say, but all the rest is true and should be kept in mind. So in the absence of an accessible lesion, it was very difficult to biopsy this patient. What are the options in this case where he had now clinical symptoms? You fear an histological transformation. There might be an infection together. You are not completely sure of what's happening. What would you do? You have to treat him. He's feeling bad. Please vote. Bendamustine obinutuzumab. So do you think it's a good treatment for a patient in whom you fear clinical transformation? I would not say that, okay? Mm-hmm. The second one is probably the routine treatment in a patient of 64. Is still eligible for autologous stem cell transplantation, is the best option. Lenalidomide, if you fear transformation, no lenalidomide. Mm-hmm. Clinical trial is always good. We will come back to that. Idelalisib, this patient is double refractory, but if he is transformed, he's not going to answer. So I think the best response was really the second one. And the fourth one, if you have the ability. So we are in a university hospital. We felt this patient may have clinical transformation, and there is nothing to biopsy. And we asked him, do you want an autologous stem cell transplantation and a salvage regimen, or we have a clinical trial, it's not chemo, it's maybe better tolerated. And he said, okay, if I can move to autologous later, if I do not lose my chances, I would prefer a clinical trial. So we tried another bispecific antibody, the one I mentioned, CD3, CD20, because in case of histological transformation, the patients were eligible, and we say, let's try 2 cycles, and we would see what happened. The performance status was 2. BIS symptoms, cervical and inguinal adenopathy are now present, but the first 2 cycles completely failed with this monoclonal antibody. So this was a big disappointment for us. And the patient was anemic, and the CRP was increasing. We had given antibiotics, and nothing happened. So this time we had the chance to do a new biopsy. And this is what was found. The novel cervical biopsy showed lymphocyte-depleted classical Hodgkin in this patient. This patient was anti-CD20 negative, so it's not a big surprise that the bispecific antibody, anti-CD3, anti-CD20, did not work. He was CD30 positive, PAX5 positive, CD15 positive, EBER negative. And when you look at the histology here, it's not really follicular lymphoma here. The CD30 positivity and the CD15 positivity. Sorry. So you have now an Hodgkin disease. We will discuss later on how this arises. What are the treatment options at this point? Remember, those patients have received R-CHOP as first-line therapy. Would you give a BVD because it's Hodgkin? Would you give BCOP? Would you give brentuximab vedotin plus ICE and autologous stem cell transplantation? Brentuximab vedotin plus DAP and ACT? Or would you give directly immune checkpoints inhibitors? Please vote. So I see still more than, a little bit less than 50% of you will give ABVD or BCOP. I think ABVD would not make sense in this case because it's nearly a primary failure of R-CHOP, so you know that an ABVD regimen is not going to do well. BCOP is debatable. I think some British colleague would do that because you have a bit of etoposide, you have other cyclophosphamide, there is a kind of intensified regimen, but still, to me, the best chances to respond in this particular cases would not be BCOP. We can't debate that. Probably the third and the fourth are the best treatment options in this patient. And of course, immune checkpoints, it's too early. It's, of course, interesting, but there is no data in the literature, and at least you should try some kind of salvage plus brentuximab if you have the ability to get that. And this is what we did. And after one cycle, the first cycle was really hard to tolerate, but he went into CR very quickly after 2 cycles, and is now moving to autologous stem cell transplantation, which just happened 1 month ago, and the patient is feeling well and is in complete response. So the learnings here. Always do a new biopsy. Even, we were in a university hospital, we could not biopsy the patient. We thought it was transformed. We thought there might be infection. We thought it was diffuse large B-cell lymphoma, and it was wrong. It was Hodgkin's disease. So even in those cases, you should think about that. So Hodgkin disease in this context is extremely complex. It only occurs in 2 to 4% of cases. It might be present at the very beginning in a subclone that was not detectable, or you might have a kind of transdifferentiation over time from the follicular lymphoma to Hodgkin's disease. But it's just to illustrate, you should biopsy and you should think that it's not always simple in transformation, and especially in case you have an inflammatory disease. Follicular lymphoma is not an inflammatory disease. If there is high CRP and no detectable infection, there is something different, so please keep that in mind. There are no standard of care here. Most of the data have been published in the era prior to brentuximab vedotin and nivolumab. We are now trying that in those few cases we have, and it looks pretty efficient. And these are some you could see for the future some references for those cases. So this was my first case.
Mm-hmm. Okay.
Thank you so much. Intriguing, Вопросы, пожалуйста.
Несут.
Hodgkin's, follicular lymphoma and Hodgkin's lymphoma. Is it transformation, or it's same disease in clonality or not? Is it possible to detect it or not?
It's a very good question, and in fact we don't know because we have both cases. We have cases showing that you had exactly the same IgH rearrangement or the same molecular T1418 in the two clones, but you also have different cases where it's more a transdifferentiation or it arises from a different clone. So we don't know. We also suppose that the treatment that you were giving had an impact, but this was not clear. In some series with lenalidomide, we thought we had more incidence of this, but this was not the case. It can also happen after our chemotherapy. So I would say maybe a majority of patients have the same clonal abnormality for the few cases we detected. So it's a true transformation, even in a different way. But you have also a small percentage that is different.
Пожалуйста.
No.
Me now? Yes. Thank you for a wonderful case. Is histologic transformation itself an indication for starting treatment? For example, for this case, when you did the first PET, and if you had biopsied and you had a transformation there, but the patient was without symptoms, would you have started the treatment?
That's a very good question. If I had a documentation of histological transformation, I would have started treatment towards a more aggressive disease.
Так, все, я думаю, достаточно для этого случая. We will continue. So the second, please.
So a second, more an easier case. So it was a 54-year-old lady diagnosed with follicular lymphoma in 2018. Grade 2, according to WHO, stage 3A, FLIPI3, was from the very beginning Guelph criteria, mainly the bulk of 7 centimeters. The patient was treated very on the classical way, 6 cycles of R-CHOP plus 2 cycles of rituximab. But at the end of treatment, she had stable disease according to IW 99 and Lugano 2014 criteria. Stable disease, okay? Performance status was 0. She reported intermittent abdominal discomfort, but had nearly a normal quality of life. She had no symptoms. LDH and beta-2 microglobulin were normal. Complete blood counts were normal. This shows you what was on the PET. This was at the beginning, here. No, this was after 6 cycles. You have an SUV max of 14, a huge lesion, nothing has changed, and you see here on the CT scan. Okay? So this is at the end of induction. What are your conclusions? Is it primary refractory disease? Is it double refractory disease? In this case, the most probable histological transformation in diffuse large B-cell lymphoma? Is it too early after 6 cycles to conclude to failure in follicular lymphoma? You may say this patient needs time to respond. Is a new biopsy required? May I have your votes? So the new biopsy is definitely required. Is it primary refractory disease? Yes. This is according to the definition. Is it double refractory? Yes. I just wanted to point out it's only a matter of definition, but then if you want to compare the different series, you need to know that double refractory means refractory to both an anti-CD20 and an alkylating agent. And more we look at that to appreciate the efficacy of a drug. Most probable histological transformation, no, because we don't know, but we have no clinical symptoms. And too early to conclude to fail or no. I think after 6 cycles of a well-conducted regimen, there is no chance that it will improve. A new biopsy of the bulky mass confirms follicular lymphoma grade 2, so exactly one of those cases you just mentioned before. What do you propose? She is 54, RDHAP plus autologous stem cell transplantation, G-bendamustine, lenalidomide plus anti-CD20, R-bendamustine, radiotherapy 40 gray. Vote, please. So as I said, everything is debatable, but I see that you are still big fans of autologous stem cell transplantation. I agree, these are ESMO guidelines, and probably 50% of our colleagues in France would have done exactly the same. But what about G-bendamustine? You are in a patient that is follicular lymphoma and is double refractory. So you are in the indication. What would you prefer, autologous stem cell transplantation, if there is no sign of transformation? Why that? So ask you this question. I can understand that if lenalidomide is not available, you won't go for that, but this would be an option. Bendamustine would not make sense if you cannot choose if you can choose G-bendamustine, at least you should change the monoclonal antibody. And I see that radiotherapy is not a favored option here. She's 54. I think it's a bit early for radiotherapy at this stage. About intensive salvage and autologous stem cell transplantation, you know, I knew that you would answer this as the first question. Is it an option according to ESMO guidelines? Is it the treatment of choice in case of transformed disease? Is it challenged by R² and lenalidomide plus other anti-CD20 combination for patients with documented follicular lymphoma? Is the benefit of ACT questionable in case histology at relapse remains FL, or should it be given to all relapse refractory patients? I think we answered this question, but I'm sure you will make the right choice. Please answer. So it's clearly an option. I think the most important response is it is a treatment of choice in a patient with transformed disease. Clearly, it is now challenged by R² if you are not transformed. The benefit is questionable in case histology at relapse remain follicular lymphoma. This is very clear now. And it should not be given to all relapse refractory patients. You have now other options, at least with the Gadolin trial. So the patient doesn't want chemo. We offer him autologous stem cell transplantation, Gadolin, and lenalidomide plus obinutuzumab, and he say, definitely, I want another treatment without chemotherapy. And you see here that after only 3 cycles, this patient achieved a complete metabolic response, a score of Deauville 3. So the disease responds very quickly to this regimen. And this patient is now in GA101 maintenance. She has finished also the lenalidomide, and she is in durable complete response in spite of being a primary failure. Questions about lenalidomide. Is it synergic with anti-CD20 monoclonal antibody? Does it restore the immunologic synapse? Is it the best option in transformed follicular lymphoma? Is it safe in combination with PI3 kinase inhibitors? is it efficient in combination with rituximab in relapsed but not refractory FL? I think this is a very easy one. Please answer. So so I think there is an opposite here in the colors. I'm sorry about that. But the good responses were the 1, it is synergic, the 2, it restored the immunologic synapse, and the 5th, it is efficient in combination with rituximab. It's not the best option in any case in case of transformed disease. So don't try that. If you biopsy your patient, transformed disease, no lenalidomide, even with an anti-CD20, even if you don't have other options. It's not safe with PI3 kinase inhibitors. Simple message. In double refractory FL, bendamustine as a single agent is a standard of care. Bendamustine obinutuzumab is approved. PI3 kinase inhibitors may provide a 1-year median PFS. Lenalidomide anti-CD20 are not efficient, and new therapies with direct recruitment of T cells against FL are the most promising. Please answer. Good. Again, the colors are opposite, but it is approved. PI3 kinase provide a 1-year median PFS in those double refractory patients. So probably you don't have access to idelalisib in this context, but if you have, you should know that it is an option that works if you are not transformed in double refractory. In fact, this is where the most efficiency has been observed. So keep that in mind. Lenalidomide anti-CD20 are not efficient. Lenalidomide anti-CD20 are efficient in double refractory if not transformed, as I showed you. And the new therapies are the most promising. That's definitely the case. And the final question, which is debatable, so when would you recommend allogeneic stem cell transplantation in this lady age 54? In case of bulky relapse within 2 years of the second line with Galen, only after failing autologous stem cell in third line, never, after any successful type of bridging, only if she has transformed disease in diffuse large B-cell lymphoma. Please answer. So the first one, in case of bulky disease within 2 years with Galen, I think this is a real question. If you have a patient that is refractory, that fails first-line regimen, that relapses within 2 years, and you have no other option in a young lady in your country, maybe you should consider that after some type of bridging. Only after failing autologous stem cell transplantation in third line, I think it's too late. We discussed autologous stem cell transplantation. We know that there is benefit in case of transformed disease. What will you expect here in a patient that is primary refractory, that had a short response duration due immunomodulation to a third line with autologous stem cell transplantation? Nothing. You will lose time. You will maybe have a couple of months, but it's a wrong strategy. I would not give an autologous stem cell transplantation in this setting, even if this is the only thing that you can do. Try maybe another solution. Never, of course, never doesn't exist in follicular lymphoma, even if we would like to say that allogeneic stem cell transplantation is only to be given in maybe 1 patient out of 50 follicular lymphoma. Mm-hmm. And only if she has transformed disease. I don't think this is the best indication, but it is an option, but not only if there is transformation. And that's it.
Коллеги, есть вопросы, есть желание что-то обсудить? Есть вопросы?
Again, I would like to ask a question. In Hodgkin lymphoma, we do PET after 2 cycles in order to make a decision. In follicular lymphoma, you have shown that you did PET after 6 cycles.
Yeah.
What is the optimal number of courses?
That's a very good question. I think so far it's very difficult to say. We should not do that too early. I probably think that after 6 cycles, it remained the best time to make some decision. It might be a little bit late if you use CHOP, probably 4 could also give an indication, but we have performed a very early PET study and then an induction PET study, and the predictive value of PET after 4 cycles was not the best. So I would still do that in the end, and probably in the future I would more rely on circulating DNA to make a decision than on PET. But too early PET is not something I would advise to do outside of research in follicular lymphoma.
And about free circulating DNA, what do you do in your institution?
So we are now starting to do that. It's not completely validated, but we look at the NGS and CAP-seq for all those patients. And you will see that probably after 2 cycles, you have a very good response in most of those cases. And then we see if there is emergence of other clone that could predict an early transformation in those cases. But it's not routine, it's only research, it's not validated so far, but it would probably be something to be combined to PET in the future to have the best predictive value to predict failure or transformation.
Так, у кого-то еще есть вопросы, коллеги? Нет? Тогда я хотела бы поблагодарить докладчиков и эксперта за очень интересные возможности дискуссии. И, наверное, мы в очередной раз с вами поняли, что фолликулярная лимфома из всех вариантов неходжкинских лимфом, пожалуй, теперь, вот на сегодняшний момент, одна из самых непонятных и сложных в ряде клинических случаев. Мы хорошо знаем стандартные, такие унифицированные подходы для лечения агрессивных лимфом. Как бы есть уже некие сложившиеся ситуации. При фолликулярной лимфоме возникают не раз вопросы о том, что должно быть сделано, как лучше поступить. Хотя уже и вариантов терапевтических опций у нас довольно много. И еще то, что сегодня вот нам так хорошо показал Франк, то, что лимфопролиферация – это очень, так сказать, интересная, очень сложная, очень непредсказуемая ситуация в клинической медицине. Действительно, мы не знаем, каковы механизмы и возможности не только трансформации, это понятно, а вот возможность сочетания разных лимфопролиферативных процессов, что должно быть у нас где-то, так сказать, в памяти, мы должны об этом думать, мы каждый раз должны подтверждать, есть ли действительно некие изменения в диагнозе и возможность сочетания 2 лимфопролиферативных процессов одномоментно. То есть такая получилась, на мой взгляд, довольно интересная секция, где мы коснулись разных аспектов развития и фолликулярной лимфомы, и вообще лимфопролиферации в целом. Спасибо большое.